Welcome back, everybody. I'm Dr. Greenberg. This is one of several videos that I'm making that is targeted primarily to service providers to help clarify important information, much of which comes from the Center for Disease Control and the World Health Organization. I want to try to take some of this information and relate it to some of the common problems and situations that arise in group homes. I want to go through what is called a symptom-based strategy that is used to determine when to end isolation for individuals with COVID-19. On May 3rd, 2020, the CDC released updated guidance about the duration of isolation that is needed for individuals with documented positive COVID testing or those with symptoms strongly suggestive and presumed to have COVID-19. This symptom-based strategy applies when testing is either not practical or a decision is made not to use a testing-based strategy to determine when isolation ends. The symptom-based approach does not rely on the need for testing, but instead looks at two primary factors: the time since the onset of the illness and the time since recovery. Time since the onset of the illness would be the date that symptoms first began, and time since recovery relates to the date that fever completely resolved and that symptoms such as cough, shortness of breath, muscle aches improved significantly and either completely resolved or nearly resolved. So we have two basic things we're looking at. We're looking at when symptoms first began, and then we're looking at when the individual had no fever and had marked improvement with near resolution of symptoms. And that would be without the use of any fever-reducing medications. So the current guidance from the CDC and based on current literature is that if an individual has been fever-free and without significant symptoms for 3 days, and if it has been at least 10 days since the onset of symptoms, then in many cases, isolation can be ended. The rationale for this is important to understand and is based on understanding the difference between an individual being infected or carrying the coronavirus and an individual being infectious. So they're two different things. Somebody can have the virus and be carrying it, but they may not necessarily be infectious, meaning they're not able to spread the virus. So understanding the difference between somebody having the virus and somebody being able to transmit the virus is an important distinction. In recent times, there have been a lot of study that has shown that many people may harbor the virus for a number of weeks after they develop the illness. But over time, that virus is not able to replicate, and therefore the individual is not infectious. the ability to culture replicative SARS-CoV-2 virus is essentially 10 days after the illness onset. The decision to use a symptom-based strategy is applicable to members of the community at large. It is applicable, for example, to staff working for a service provider that are not involved in direct personal supports. And in some cases, it may be applicable to direct support professionals. The caveat to using a symptom-based strategy is that we don't know for sure how long individuals are infectious. It is our best estimation based on the data from the CDC that 10 days since onset of symptoms and 3 days since resolution of fever and symptoms is the point at which infectivity ceases. But this is not an absolute. Therefore, in certain cases, local practice and guidelines may be more conservative. The times where one might choose to have a longer waiting period, or where one may choose to use a test-based strategy, might include in cases where an individual is immunocompromised, since we know that these individuals may possibly be infectious for a longer period of time. Individuals with clinical symptoms, which then resolve, do not have virus that is able to be cultured when their symptoms have been absent for 3 days. The use of a symptom-based strategy is applicable in many cases. However, there are some cases that are recognized by the CDC as being situations where a more stringent threshold is needed. This may be because the risk of being wrong in an unusual case is much greater. A couple of these situations are as follows. Individuals who are immunocompromised may shed the virus and be infectious, possibly for a longer period of time. Another case where this symptom-based approach may need to be reconsidered would be in cases where individuals are potentially at risk of infecting large numbers of people, such as healthcare workers in a hospital. A third case would be individuals that work in a congregate setting, such as a nursing home, and by extension, possibly some service-provided group homes. These have to be individualized decisions. The CDC recognizes that no strategy is going to be 100% effective. I think a good way of becoming familiar with these guidelines is to give a couple of examples. Let's take the first example. You get a call from a parent of one of the young adults who's served in one of the residential homes, and the parent indicates that on the first of the month, they noted fever, headache, and a sore throat. They went for testing on the 3rd of the month and were found to be COVID positive. They've been isolating themselves at home, and it is now the 10th of the month. They tell you that the fever and all the other symptoms have largely subsided. They have no more fever or not on any medication and have no cough, no shortness of breath or anything else. So our dates are the 1st of the month was when symptoms began. They tested positive on the 3rd, and they've had no fever or other significant symptoms for at least 3 days. What do you think? Do they need to continue isolation? So the answer is no. They're a general community member, a parent. They're not in a high-risk profession where they could potentially result in spread to a lot of other people. They have had 10 days since the onset of any symptoms, and they've had no symptoms or fever for the last 3 days. This would meet the criteria for ending isolation.